question. Right. So if you have read and understood, considering its surgical pathology station, kindly tell me what are the differential diagnoses that you'll consider for this patient?
So it could be a basal cell
Very
carcinoma
good.
of the nose.
Yes.
It could be a squamous cell carcinoma,
Yes.
possibly actinic keratosis,
Very good.
or a Bounce disease,
Very good.
or
Okay.
it could be even malignant melanoma.
How would you
Yeah.
confirm your diagnosis?
I would do an excisional biopsy,
Yes.
and then also I could do an excisional biopsies or full or punch biopsy.
Okay. You can even do the blood test normal,
Yeah,
other than because
that.
biopsy is biopsy. All right. Once
Yeah.
you are taking biopsy or punch biopsy or whatever sample that you have to take, what are the things that you would keep in your mind?
So here we'll have to see that whether the margin involvement.
Yes.
Then depth of invasion.
Very good.
Whether then the type of the histologic variant of the disease. Then
or if there
how
is
much it has spread.
ulceration
Any ulceration, if there is any palisading, then if there is perineural and perivascular invasion, and also if there is aneuploidy and expression of P53.
Yes. So you'll do the tumor markers for that. Okay.
Yeah.
Can you please tell me what are the 5 major steps of metastasis that you should consider or keep in your mind?
Cell metastasizes in, first of all, there is invasion and infiltration of the surrounding tissue with penetration into the small vessels or lymphatics. Then there is release and survival of these cells within the circulation. Then they get arrested or trapped in the tumor, trapped in the capillaries or in the lymphatics of any distant organs. Then there is permeation and penetration of the lymphatics and or the blood vessels, followed by survival and growth of the tumor cells within that organ.
Okay, you've done the biopsy and it comes out to be basal cell carcinoma. What next? How would you manage this patient's
So here we will check the here we will see the depth of invasion of the tumor, and we'll see the then we'll have to go for we can go for either surgical procedure or non-surgical methods. Surgical methods can be such as excision of the tumor with primary closure, or by grafting or flap, or by secondary intention. Or we could go for curettage and electrodissection. Then we could go for cryotherapy with liquid nitrogen. Non-surgical methods where we can go for topical photoablation with delta aminolevulinic acid in 20% emulsion. We could go for 5% topical fluorouracil or 5% topical imiquimod.
Good. Thank you. Can you please tell me what measures would you take to make sure or to avoid recurrence?
This is mostly first of all, during surgery we can go for Mohs micrographic surgical excision.
Yes, or the frozen section. Okay.
And frozen section.
Just okay. One management. When you were telling me, you said you'll Go for primary closure. Okay, just suppose because I told you it turned out to be basal cell carcinoma. So when would you decide not to go for the primary closure?
If there is surrounding, the patient is having some sort of infection or there is in sepsis, then in that case we'll have to go
size as well. How much?
And also size, if it is depending upon the margin involvement, usually within 4 millimeter depth, then we'll go for 2 centimeter excision.
Okay.
A clear excision.
In that case, you have preferred secondary
intention, healing with secondary
healing,
intention.
yes, secondary closure. So secondary closure is not taking place as planned. There is infection. You take a swab. What is the most likely organism you expect to find there?
It would be Staphylococcus aureus.
Yes. So how would you go about and manage that?
Then we will go. We'll have to go for culture sensitivity. Then start antibiotic according to the local, according to culture report or according to the local hospital guidelines.
NHS, yeah, trust guidelines.
Trust policy.
Yes. Right. You've sent. If you've sent the culture and sensitivity for MRSA. So what is MRSA? Wound infection.
It is wound infection with methicillin resistant Staphylococcus aureus.
Yes.
In that case, it depends upon what sort of infection, the severity of the infection. If the patient comes out as an outpatient case, in that case, we'll go for oral antibiotics. We'll give oral clindamycin or amoxicillin. Along with that, we'll give tetracycline or linezolid. And if the patient is having abscess, in that case, we'll go for incision and drainage first, and then go for antibiotics according to local trust policy. If the patient is having severe infection, in that case, we'll hospitalize the patient, then intravenous antibiotics to be given. We can give linezolid 600 milligram for 7 to 14 days, 12 hourly, or clindamycin 600 milligram IV. Simultaneously we'll do decolonization of the with mucorosine nasal and chlorhexidine body for body decolonization.
Okay, good. Thank you. Can you please tell me now a wound has been healed and there is still gap and you want to fill the gap with the graft. What type of skin grafts can you suggest? And after, first question is there. From where would you take the skin grafts?
Skin graft, we can take it from the ear lobule or from the fascia lata.
You've made your first attempt of skin grafting and the wound has become infected. What would you do then?
In that case, I will have to remove the graft, and then I'll have to continue management of thorough wound debridement and regular wound dressing, and until there is simultaneously I'll have to take wound swab and send for culture sensitivity, staining and culture sensitivity, and then I'll have to give antibiotics according to the culture report or according to the local antibiotic trust policy.
Good. Just suppose you don't remove the graft, what are the consequences that can happen?
There could be infection. The patient could go into sepsis and graft failure.
Yeah, graft can lead to squamous cell carcinoma.
Graft can lead to squamous cell carcinoma.
If you don't operate, don't remove it. Okay, good. Thank you. What do you see? Can you describe?
This is a well-defined circular lesion, raised lesion with pearly keratin formation on top, with surrounding inflammation and telangiectasia. Possibly this is a specimen of basal cell carcinoma.
Good. Okay, thank you.
Thank you, ma'am.